Welcome to this special edition of Diabetes Core Update, where we are going to discuss the new oral GLP-1 receptor agonist. Now, this is exciting. We know GLP-1 receptor agonists and the dual GLP-1 GIP receptor agonist have completely changed the face of obesity management. We know that's not news. Until recently, they've only been available for obesity management in an injectable formulation. Patient preference studies, though, show that about 3/4 of patients would prefer to take an oral medicine rather than an injectable. This isn't a surprise. We know that from our conversations with patients. But due to the fantastic efficacy in both weight loss and metabolic parameters, the injectables have become very popular and have produced fantastic and very important results for the people for whom they are indicated. Nonetheless, both clinicians and patients have been hoping to have an oral option for obesity at some point, and that point has now arrived. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special series of Diabetes Core Update is sponsored by Novo. Recently, the FDA approved for the first time an oral GLP-1 receptor agonist, and that is oral semaglutide. Since this is now available, we are going to focus today on oral semaglutide. In a future episode, we will discuss another oral GLP-1 receptor agonist that was submitted to the FDA in December of 2025 and is currently under review, and that is oral orforglipron. Today, though, we're going to focus on oral semaglutide because that is what we have available now and is what is currently FDA approved. And we are really privileged to have joining us today Dr. W. Timothy Garvey. Dr. Garvey is an endocrinologist and the Butterworth Professor and University Professor of Medicine in the Department of Nutrition Sciences at the University of Alabama at Birmingham. If you've been reading the medical literature on obesity, you are already familiar with Dr. Garvey's name. His name is on many of the pivotal trials in obesity that have come out over the last few years. He's published over 350 articles that range actually all the way from the pathophysiology of insulin resistance to obesity clinical trials. Welcome, Tim.
Thank you very much, Neil. It's really a pleasure to be here and to speak with your audience.
Tim, let's start by going over why the GLP-1s, and that began 20 years or so ago with exenatide, were initially developed as injectables.
These are peptides, Neil, and as ingestion of peptides, like any other protein, rapidly leads to digestion into individual amino acids and absorption, so you lose any kind of drug effect there. So they, by necessity, they had to be systemically administered subcutaneously. You mentioned the early 2000s is when we had exenatide, and that started out, that was the first GLP-1 approved for human therapies with daily injection, and then the molecule was modified to allow for weekly injections for delayed, prolonged half-life in PK studies. So that's where we began, and you know where we are now. We have
yeah.
Yeah.
And it really has been remarkable, not just on the chemical side, the formulations, but even the engineering side, to have the devices that we have now that make it so easy for patients and are so much really better devices than the original exenatide device years ago. And a lot of people don't appreciate the amount of work that goes into all of that, from engineering to the creation of an orally available formulation of semaglutide. Can you share with us a bit about that process? What were some of the challenges in moving toward an oral formulation? How were those challenges addressed?
First, in terms of prolonging the circulating half-life of the molecule, regardless of whether it's oral or injectable, there was amino acid substitutions, including an amino acid substitution that prevented degradation by DPP4. Then there was a spacer added attached to a long-chain fatty acid, and this fatty acid adduct allowed absorption to albumin in the circulation and prolonged its half-life in that manner. But it was a whole nother ball game in terms of bringing this into an oral formulation. We've been trying to get oral insulins for some time, and it hasn't really worked out that well in other peptides. What happened here with Novo Nordisk is they contracted with another company that developed this product called SNAC, SNAC, and it was a matrix in which the semaglutide was embedded, and it prevented digestion of the protein in the stomach. And when it approached the gastric mucosa, it changed the pH locally to a more basic pH, which allowed absorption of the molecule semaglutide into the systemic circulation. The absorption isn't perfect. In fact, it's fairly poor, 1.5% to 3%, something in that order of magnitude. And that's why the oral doses are, in terms of milligrams, are so much higher than the injectable doses.
It's fascinating. And it just, for us in primary care and endocrinology to hear how that basic science moved along gives us a better appreciation of what goes into the medicines we use every day. Let's move on now to the clinical trials of oral semaglutide, which is the evidence that allows us to use it every day. And can you go over some of those clinical trials? And of course, mentioning weight efficacy as one of the endpoints.
Please, with the oral semaglutide, these are the OASIS trials. And OASIS 1 was a dose of 50 milligrams, maximal treatment dose. And so it's 50 milligrams a day once you achieve the full dose. This was very effective. It led to about a 15.1% weight loss. And this is using their treatment policy estimate, analogous to an intention to treat type of analysis. So that's pretty good weight loss. You get into the 15% range. I call these second generation medications because once you get that sweet spot, you're able to treat and prevent a broad array of obesity complications. So this level of efficacy for weight loss really gives us a tool to improve quality of life and to prevent and treat the complications, which really confer morbidity and mortality in our patients. So that was good news. Of course, this was at a period in time when the company had greater than expected demand for their drug and was having problems kind of supplying it. And the 50 milligram dose compared to a 2.4 milligram dose injectable, that's a lot of semaglutide devoted to an oral preparation. So OASIS 4 explored a lower dose, half of that, 25 milligrams a day. Of course, there's an escalation up to that we can talk about later. But once you get to 25 milligrams, and here we still had good news. The intention to treat type of analysis was 13.6% weight loss. If you looked at a completers type of analysis, it was over 16% weight loss. Again, very good weight loss efficacy, maybe a little less than the 50 milligrams, but in a range where we're still able to bring a lot of health benefits to patients. And so the 25 milligram is what was pursued for FDA approval. It was approved January 5th, not that long ago. And we've really seen a lot of patient interest in this oral formulation.
There sure is. As recently as yesterday, I saw someone in the office who was actually asking about switching from their injectable to oral semaglutide. Can you go over some of the other endpoints? Because as you mentioned, these are medicines where the goal isn't just weight loss, but is improvement of health outcomes. What are some of the metabolic endpoints that we're seeing in OASIS 4?
Yeah, we saw a lot of cardiometabolic disease risk factors improve. These patients in OASIS 1 and OASIS 4 did not have diabetes at baseline, but the hemoglobin A1C came down 0.3% units. Fasting glucose came down, of course, about 6 milligrams per deciliter. But another thing I was impressed by, and this goes along with all these GLP-1 based medications, is the fasting insulin levels came down in these studies as well, 25 to 30%. Together with the decrease in fasting glucose. And this is really indicative of a marked improvement in insulin sensitivity. Some of this, I guess, this could be attributed to the weight loss, but perhaps there's other drug effects operative here. But regardless, as we know, insulin resistance is the core lesion in cardiometabolic disease. And when we see an improvement in insulin sensitivity like this, we can expect improvements in glycemia, as well as some of the other benefits we saw in OASIS 4. The triglycerides came down. The C-reactive protein also came down. In this study, though, the blood pressure came down, but it was equal to placebo. There seemed to be a more pronounced effect on blood pressure lowering in this study in placebo. We're talking about 4 or 5 6 millimeters of mercury, diastolic, systolic, but there weren't significant differences there. Not quite sure how to interpret that. Usually with these GLP-1 based medicines, we do see a significant decrease in blood pressure. Good. And then in terms of patients that started out with prediabetes, over 75% of those were converted to normal glycemia by the end of the trial. That's good news. This wasn't a trial designed to look at prevention of progression to overt diabetes, but I think given those results, we can predict that this medication might also have that beneficial effect.
Yeah, that's pretty amazing and so important because almost half of the population has either diabetes or prediabetes, a substantial number having prediabetes. So critically important. Did they look at physical function?
Yes, there were some sub-studies looking at changes in body composition and physical function. The body composition, I think, it aligns with any, in my opinion, aligns with any modality producing weight loss, whether it's bariatric surgery or obesity medications. We see when we measure body composition using DEXA scans, we see about a 1/3 decrease in lean body mass and about 2/3 decrease in fat mass, with a preferential loss of fat from the visceral or abdominal compartment. In terms of the functional studies, this was really done with a sit-to-stand maneuver, how many sit-to-stand repetitions you can achieve over a certain time period. And that was reassuring also. I think there was no decrease. In other words, the number of sit-to-stands at baseline was statistically similar to the number at the end of the study. So there was no weakness as manifest in that way. But I think in addition to that, there were patient-reported outcome questionnaires assessing quality of life and physical function, and those improved as well. Both of those improved. So, and they also improved in people that had impaired physical function at baseline. So I think this muscle loss is something we need to study more carefully. It's something we need to pay attention to and make sure our patients have adequate protein intake, and we advocate walking programs and particular resistance exercise. But it doesn't appear to be a clinical problem in most patients in terms of any kind of adverse effects on quality of life or activities of daily living and physical activity and functioning. We'll just have to see where the research takes us there.
Yeah, and those are important things, I think, for our listeners to be aware of. In the studies, I'm assuming in the OASIS trials, as it was in all the other GLP-1 studies, patients received regular advice on lifestyle, on diet and exercise. Is that correct?
That is correct. I would say, I think most sites had dietitians study. My site certainly had dietitians as study coordinators and able to talk to patients. And yeah, that was part of the protocol. Kind of a standard advice type lifestyle intervention for both diet and exercise.
Yeah, and something that I think is so important is that these medicines, therefore, in order to achieve the results that they do, really are optimally prescribed by people like those who listen to this podcast, clinicians who talk to their patients, not patients just going to some online site without any interface with any healthcare professional and getting medicines. And we've talked on a different one of our podcasts about all of the problems with compounded medicines, with these online sites, but that it is very reassuring to hear that in the studies, people maintained their physical function, had improved quality of life, and all the metabolic parameters. Any other adverse effects? I imagine the same usual adverse effects we see in other GLPs.
You're pushing a button of mine when it comes to online availability of these prescriptions without evaluation by a healthcare professional. So I know this podcast is not designed to go there, but so I'll stop.
Please. We share the same concerns, and it's something we've talked about in detail. So I'm glad that we both share that concern.
Yeah, the same GLP-1 receptor that in the hypothalamus and brainstem that mediates a decrease in appetite is also the receptor in the area postrema that mediates nausea. So the oral preparation does not get around these GI side effects that is also observed, of course, with the. So like the injectables, there's about a 40-45% prevalence of nausea. less so for vomiting, more like 30%, and constipation and diarrhea are down there about 20% of patients. So a lot of patients do fine, but a significant proportion of patients do have these GI side effects. I don't think that was to be expected, I believe. And again, like the injectables, they occur primarily during dose escalation and then get better over time, usually mild to moderate, only infrequently requiring discontinuation of the medication. So the GI side effects were not surprising and still in what would be expected with any GI-based medication, I believe.
And I noticed in reading the paper, there was something I was not as familiar with, dysthesias.
Yes. This occurred in about 5% of patients in the Oasis 4 trial. We first began detecting this in the called step-up trials with higher doses of subcutaneous semaglutide up to 7.2 milligrams per week compared to 2.4. In those studies, close up to 20% of patients had these dysesthesias. What does a dysesthesia mean? These patients, that's a general term, but these patients usually feel just sensation and it just doesn't feel normal. It can be tingly. It can even have some painful characteristics to it. The worst I've seen is a patient who had problems putting on it. It was so painful. And this gets better pretty quickly once you decrease the dose or stop the dose, depending upon how much it's bothering the patient. There may be higher incidences of this because patients just probably don't even mention it because often it's very mild and patients just brush it off and it can get better over time. I'm not sure what the mechanism of this is. I'm not an expert in neurology, but I did look this up, and there are GLP-1 receptors in peripheral nerves. I don't know if that's part of this, but I think that's something we have to be aware of in our patients. And I think this is true with any GLP-1 based medication. We'll see a certain percentage of patients have dysesthesia, but the higher the doses, I think that's when we bring this out more.
Thanks for going over that, because that's new information that's certainly helpful to know if a patient has those symptoms. Let's now go on and talk about cardiovascular safety and efficacy. Where does that fit in?
Yeah, this was also, I think, good news. We know the SELECT study, and this was probably one of the more important studies ever performed in obesity. It was a cardiovascular outcomes trial, of course, in patients just with obesity, not diabetes. 17,600 patients internationally followed for 4 years, and we saw about a 20% decrease in the hazard ratio for cardiovascular disease events with semaglutide 2.4, the injectable. And this was secondary prevention. So these patients, for the most part, had a cardiovascular disease event to come into the study, or at least were very high risk. And in the labeling for oral semaglutide, this indication for secondary prevention of MACE events, major cardiovascular disease events, was carried over to apply to oral semaglutide. So the oral semaglutide 25 milligrams also has an indication, FDA approved indication for cardiovascular disease prevention.
That's so important because my sense clinically, to be honest with you, is that a lot of my patients who we co-manage with the cardiologist, that the cardiologists are not as quick to use GLP-1s because they're hard medicines to use. You get a lot of callbacks from patients and they don't have the years of experience that we in endocrine and primary care do. So we see a lot of patients with coronary disease who are overweight and obese. And it strikes me that a lot of them are not automatically put on a GLP-1 the same way as they are some other cardiovascular risk modifying agents. And I suspect that having an oral agent available will be very attractive and make that easier.
I suppose in terms of the inject, of course, I've been a diabetologist for 35 years or whatever. And I've had so many patients on injectable medications. And we have in endocrinology practice, your patients, you just have a cadre of patients that just don't mind injectables as much, I think, as the general population. I could be wrong about that, but I think the cardiologist, this isn't like a statin, where you put patients on a statin, you check the lipids in 3 months, and you're good to go. This is a medication where you're right. We do have to manage patients a little bit more actively, deal with their side effects, manage the weight loss. We want healthy degrees of weight loss, not excessive, and we want to reach our clinical health targets as well. And we need to adjust other medications. We may need to decrease any other blood pressure lowering medications that patient might be on, blood glucose lowering, and blood pressure lowering medications that they're on. It is a little bit more involved than a statin, for example, I believe, in my opinion.
Yeah.
The oral, they're still going to have those challenges in terms of managing the weight loss, side effects, altering other medications, just integrating it into their overall treatment plan for their whatever diseases they may have.
That's a really good point. Let me ask you something that's on the edge of what we know, but I'd be really interested in your opinion. Increasingly, we're doing coronary calcium scores in order to risk stratify. If someone has a calcium score of 0, they're at very low risk. But when you have a calcium score over 300, and this has been shown in a number of studies, the MESA study by Matt Budoff and others, a calcium score over 300 has about the same risk of an event as someone who already had a heart attack or stroke. And based on data like that, the National Lipid Association 2025 guidelines state that for people with a calcium score greater than 300, an LDL goal of less than 70 is recommended. Should we be thinking in this group to treat them if they have a calcium score, whether it's over 100, over 300, similar to the way that we should be doing for people who have established coronary disease, thinking about a GLP-1 as a way to risk reduce in individuals who also have overweight or obesity?
A lot of patients with obesity will have metabolic syndrome or one or two metabolic syndrome traits. We know they're insulin resistant. We know they're in a state of accelerated atherosclerosis before diabetes or the first cardiovascular disease event comes to the fore. I think so if they have overweight or obesity. And in the SELECT study, we know that almost all of these, I think 80% of these patients were already on statins. So this cardioprotection is over and above what statin brings to the table. I think there's very good evidence to support that your contention there. We should think about adding GLP-1 too as an additional, or if we're going to choose a medicine for obesity, let's choose one where there's evidence basis for cardioprotection, particularly in patients that have already had an event.
That makes sense. Thanks for addressing that, because I think that comes up and it's often not entirely clear. Let's go over now some practical aspects of prescribing oral semaglutide. What should our listeners know?
Well, some people like the oral semaglutide because it looks like they're going to be lower cost than the injectable, but that's a big changing field right now. We'll have to see where all these costs level off. But it's still a GLP-1 based drug. We're going to need dose escalation. With oral semaglutide 25, we begin with a dose of 1.5 for a month, daily for a month, then go up to 4 for another month, then to 9. And then on the fourth month, we're at 25 milligrams a day. And they're prescribed the pills are in bottles with 30-day supply for each of these doses. Like single-dose injectable pens, we may have patients who want to keep at a lower dose before we escalate to the next higher dose. Then we're going to have to get 2 prescriptions for a lower dose, and it's only the 25 milligram dose that's approved for treatment. Again, it's a challenge for clinicians to work our way through pre-authorizations and insurance companies and all of this stuff to get the medicines that our patients need. We're familiar with those problems. And with the oral preparation, because of the SNAC matrix and the way this medicine's absorbed, we need to take these oral semaglutide in the morning before we've had anything to eat with a half a cup of water, about 4 ounces of water, and not eat anything for the next 30 to 60 minutes or so, at least 30 minutes. So we're going to need to delay breakfast, and that includes coffee. Patients I've had, they do very well with that. It's not a big imposition, and they seem to do okay with that. But it is, if you don't adhere to that, your absorption is not going to be what you want. And so your therapeutic efficacy might fall off. So it is important to pay attention to that.
Okay. And the half-life of semaglutide on the oral pills is the same as semaglutide by injection. Is that right?
That's correct. Once it gets into the bloodstream, it's the same.
And then a question that I've heard asked, if someone is switching from injectable semaglutide to oral semaglutide, do you just guess that they're in that same dose range? If they're on a middle dose, convert to the middle dose of oral. If they're at the max dose of 2.4, go to the 25, or is something different here?
Yeah, we don't have any data to for guidance there. But just think about the half-lives. With the injectable, once a week, the half-life is 5-6 days. If you just stop the injectable on day one and start with the same dose of pill, those pills are going to be adding on to the dose. The full dose is going to be add additional to what you achieve with the subcutaneous dose. So I would wait at least a week, I would say, at least, before you begin the oral semaglutide after injection. That's number one. Just
helpful. Just
making sense of the PK. And if there's a patient that's not having any GI problems, I would go to if they're on 2.4, I just go to 25. If the patient is having kind of some GI problems and intermittently, just not dealing with that top dose of the injectable is perfectly, I might start at a lower dose of the oral just to be on the safe side. I mean, remember, it's not a race here to get patients up to the maximal dose. These patients have a lifelong disease, and we don't want to make them disconcerted through precipitating GI side effects unnecessarily. So it's always better to be more conservative, I think. Take your time.
Yeah, that makes a lot of sense. And thanks for going over it in that detail, because I think that is going to be happening, and it's helpful to have just logical guidance about how to approach that. We're about out of time. Do you have any final thoughts for our listeners?
Two things, Neil, if I may. First, I've been fortunate to give in the last 6 months, been to several foreign countries giving talks to doctors about obesity. And these doctors in some of these countries don't have some of these medicines available. They know the data, the papers are published, and they really want to get their hands on these medications. I was in Peru in particular and concomitant with the launch of an injectable GLP-1, and we're driving around Lima, Peru, and I see these pharmacias, these little pharmacias about every second block. And I say, all these pharmacias have refrigerators to store the injectable. And they said, no, only about 1 in 5 do, and those are the ones we're going to have to work with. The advantage of the orals is they don't need to be refrigerated. So I think in terms of worldwide distribution and accessibility, this is a very good thing. And even for our patients in America here, for travel, it can just easier to store the medication and travel issues, and you can travel with the medicine better. When you look at real world data, and we see that half of patients don't stay on these medications after we prescribe them after a year, you realize we're treating this disease very poorly, because we know that most patients regain weight and lose the health benefits of the weight loss. So we'll have to see how this plays out. Hopefully, if patients prefer oral medications, we know that they're more likely to be adherent to a medication when it's delivered in the format that they prefer. Maybe this will enhance adherence over a longer period of time. We'll have to see. But that's another hope of mine with the advent of these orals.
Dr. Timothy Garvey, thank you so much for joining us.
My pleasure. Thank you.
And most of all, of course, thanks to our listeners. Thank you for joining us on this special edition of Diabetes Core Update, discussing new, exciting information about the now available oral GLP-1 semaglutide for obesity. This special edition of Diabetes Core Update is sponsored by Novo. We have gone over both the data, and Dr. Garvey has really been wonderful in going over not just the evidence, which he knows better than anyone, but also practical hints about this medicine and even issues of worldwide distribution and the importance of that. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.